and we are hopeful that we'll continue to do it over the next weeks as committed on every Saturday. So today the topic is going to be on community acquired pneumonia, and we are going to have our examiner, none other than Dr. Matthew Pulikan. We are happy to welcome you, sir. Having a senior faculty with us is a real blessing for all the students. And we are also happy to welcome Dr. Setu Babu, who will be also accompanying along with Dr. Matthew sir for today's topic. We also wish best of luck to the examinee, Dr. Divya, as well as Dr. Ranjit Chandrasekhar Nair for today's topic. So with this short note, I hand over this session to Dr. Matthew sir. Sir, it's all over to you. Please go ahead, sir.
Yes, good evening, everybody. I think we'll start the session as soon as possible. So, Ranjit and Divya, I think you're all ready now.
Yes.
Okay, great. So, I'll just share the slides and we'll go through the scenario and we'll just keep on asking you questions. Take it as you can. Okay, fine. Let's go. Let me see whether I can share the slides. 1 minute. All right. Can you see my slides?
Yes, sir.
Yes. Wonderful. Okay. So we'll start with the case scenario. We'll just start off.
Yeah. So, good evening, doctors. So, we will begin with the presentation. So, we have a 30-year-old female who presented, who is having a known history of diabetes and hypertension, who presented with symptoms of fever for 2 days, cough for 2 days, left side chest pain for 2 days, and breathing difficulty for 1 day. Okay. And on arrival to the ED, her vitals were, she was having a heart rate of 120, respiratory rate of 32, BP of 230 by 120, and saturation of 77% at room air. On examination, she was conscious, oriented, and obeying commands, and there were left-sided hoarse crepitations were possible. Right.
Okay. So before we go to the possibilities, could you just summarize this? I think it's already a summary, but okay.
30-year-old female with the comorbidities of diabetes, hypertension, now presented with a short history of cough, fever and left-sided chest pain, and a 1-day history of breathlessness. At the ER, she had a tachycardia, tachypnea, and the BP of 230, 110, and a saturation of 77% on room air. On examination, GCS 15, and she has got a left-sided crepitations on clinical examinations.
Yes. Other systems examinations were unremarkable. Okay.
Yes.
Fine. So what are the possibility now? What do you think? What are the differential diagnoses that you can think of?
With the short history of 2 days of fever, cough, we definitely think of a infective pathology. So with the respiratory symptoms of saturation fall and the chest pain on the left side, if it is pleuritic, I think so. We definitely think it has a infective process, maybe a community acquired pneumonia. Maybe we will consider for this patient. But patient having a higher BP with the with one non-case of hypertensive and a higher BP comorbidities, we think next will be a isolated hypertension with a acute pulmonary edema. And just third differential would be we consider as chest pain with a switch of BP, might be a acute coronary syndrome.
Correct.
And the fourth differential we would like to take is maybe a left-sided pleuritic chest pain. We can include a pleural diseases like a pleural effusion can be taken.
Good.
And fifth, the patient is 4 differentials.
Reasonably all right. Okay, right, fine.
When there is an
That's fine.
acute chest pain with acute breathlessness, what other DD you have to consider?
Hypertensive emergency, pulmonary
Pulmonary
embolism.
embolism and
That,
pneumothorax.
all you said, right?
Right, yeah.
Apart from that,
Mm.
a pneumothorax is a differential diagnosis,
That you should think of, yeah.
and also a pulmonary embolism. That's also 2 other important differential diagnoses to consider. Okay.
Even though that fever and this
Mm.
thing does not, probably not there, but yeah, I mean, will not probably exclude that as the last one, or we'll keep it as the last one. As I said, your pneumonia would come as one of your first diagnosis in this case. All right, okay. So suppose a patient comes to you with this, what are the investigations, the first investigations you would like to do on this case?
When we see the patient in the ICU, we will first send
On the emergency, let's say this patient has come in. Usually, when he comes to the ICU, all your
If the
primary investigation would have
emergency.
been
Okay,
done.
sir.
So, if you're seeing this patient in the emergency, what are the investigations you would like to see or order?
we'll get an
Chest X-ray. We will do a chest
Chest
X-ray,
X-ray.
and
Definitely,
a focus examination, lung ultrasound,
Very good.
chemical
and
in ECG,
ECG.
ECG, 2D echo.
Okay.
And
Come in your focus, but yeah, okay.
Yes, sir.
then
What
blood investigations like
Right.
total count
Very
and
good.
cardiac enzymes.
Excellent. Yeah.
Yeah, inflammatory markers.
Hmm.
We will send it
All
to
right. So these are the initial investigations that you'll do. Will be your CBC biochemistry, that LFT, RFTs,
ABG.
ABG. Yeah. Your sugars you should always take because this patient is already a diabetic. Yeah, ESR, procalcitonin, CRP will help you. Then ABG, of course, chest X-ray, ECG, cardiac enzymes you need to do. D-dimer because hypertensive pulmonary embolism, your pulmonary edema was one of your DDs. And of course, focus. It will rule out a lot of your differences like ACS, your pneumothorax, all that can be, and even your CAP can be ruled in with focus examination. So these are the examinations initial examinations you will order. Okay, fine. So this was the investigations that we got. Okay, so have a look at that for this lady. Okay. Right. All right. Then there's other
Pro-BNP results,
Pro-BNP, ureacreatinine,
RFT, and LFT results.
Tropi also. Yeah, Tropi, repeated Tropi was negative. Yeah. All right. That's the ECG. What do you see in the ECG?
Sinus tachycardia
Right.
with normal axis with poor R wave.
Okay, yeah.
Poor R, there was no R wave in the R wave progression.
Ideal, yeah, okay.
There was T inversions in the 3 and on the lateral lids of only 3 there is small
Only 3, I think. Yeah, that's also borderline.
Borderline.
Small ectopic is there, atrial ectopic, but otherwise
Sinus
tachycardia. Yeah,
Sinus
sinus tachycardia is what it's. Right. And this is the chest X-ray. Can you comment on that?
Yeah, chest X-ray, a portable chest X-ray, maybe AP view and taken, and there is a exposure is adequate, showing a non-homogeneous opacity on the left upper and lower zone. Upper zone mainly. With the cardiac borders are, but we can still distinguish.
Correct.
And there is no, so we cannot see because of the window of video window on the chest X-ray. Now I can see.
What do you want? What can't you see?
No, because of the video, this one was on top of the X-ray here in the screen. Now we can see, sir.
Okay. Sorry. All right. Okay.
The costophrenic angles was at the right side it is clear, and the left side there was blending.
Possible blending. Yeah. Okay.
Apexes are normal, and
What about the right side?
right side it's normal, sir. Normal. There was
There are some nodular opacities on the
certain
right side.
nodular opacities are there.
So what is your impression on the X-ray?
It's
What are your possibilities for diagnosis or
possibilities.
differential diagnosis? Is it pneumothorax?
No,
No,
sir.
sir.
It's not on motor. It might be a consolidation on the left side.
Consolidation with the effusion.
Consolidation with the effusion, that still we have to roll out with the
Consolidation
US.
with effusion. Yeah.
Okay.
Is it a multi-lobar consolidation or a into a single lobe? What do you think?
Upper lobe is mainly involved, sir. With the lingula is involved more. Lower lobe is the maybe because of the effusion. We cannot might be effusion or multilobar.
Multilobar.
Looks like more or less a multi-lobar
Multilobar.
consolidation with an effusion more likely. Okay. So can you exclude pulmonary embolism with this X-ray?
Pulmonary embolism, usually the wedging will be in the peripheral, more peripheral, but the X-ray showing more on the central opacities, and still there is a right side RV. There is no cardiac silhouette is still intact with some there is no sign, knuckle sign. There is no knuckle sign or any the pH features are there still. So
All right.
the pulmonary embolism is less likely with the X-ray, but the effusion is still having some.
Yes, there is an effusion possible. Okay, there's an ABG here. As soon as the patient came in, it's in room air. Okay. Any comment on that?
Saturation 84. Mild air, yes. Say ABG showing no acid-base changes, but there is little bit of hypoxemia with the mild ARDS. PF ratio is between 200 and
200 and
300.
Between 200 and 300.
Between 200 and
300.
300. All right. So yeah, around
And the
220,
glucose is
230.
sugar also high, 250.
Exactly. Yeah.
Then
Glucose is high, and of course the PF ratio is on the lower side.
lower side.
Acid
And the
base,
saturation is 84.
84%. And the electrolyte state has potassium of 3.2, and the positive is other glucose is 255, hyperglycemia is there.
yes, this is a diabetic patient. Okay.
Yeah.
So this is how the ABG came in. All right. Okay.
So what is the prominent finding in the ABG?
Hypoxia is there.
Hypoxia.
Okay. Type 1 respiratory failure. Right.
Okay. So what's your diagnosis?
The diagnosis now a community acute pneumonia with mild ARDS.
Okay.
Multilobular left-sided community acute pneumonia with mild ARDS.
Okay.
Some infiltrates
With the-
were there on the left on X-ray. Some infiltrates, nodal infiltrates were there on the
That's
other
fine.
side
Okay.
also.
Okay, correct. Yeah, a possible ARDS is also there, right? Okay.
Yes.
All right. CAP, lung conservation, type 1 respiratory failure, also hypertension, possible.
Sepsis because of the total
Sepsis.
count was 2000.
Yes, it was very low. Okay.
Leukopenia was there.
Leukopenia. Which is more dangerous, leukopenia or high leukocytes?
Leukopenia.
Leukopenia is more dangerous. Yeah. Okay. So possible sepsis, of course, diabetes also was there, no? Uncontrolled diabetes. Yeah. So can you tell me some of the risk factors for community acute pneumonia?
Factors, comorbidities like diabetic hypertension, liver diseases, comorbidities like COPD, bronchiectasis, lung pathologies, other lung pathologies, and elderly, heart failure, previous heart failure, and smoker.
Smoker, yeah, definitely.
Smoking is another risk factor.
Social risk factors are crowding and poor
socioeconomic
Okay.
and
All right. We'll go through that. Okay, older age, comorbidities, as you said. Okay. It's always nice if you can categorize that. It will be easier for you to say. Okay, so you say older age, comorbidities, and then usually viral infections, because usually viral infections predominantly, that can cause CAP itself. And then if you have something like influenza, then it can be followed by a bacterial infection also. Right. Impaired airway protection is another that will increase the risk of microaspiration, like stroke, seizures, anesthesia, alcohol, or esophageal dysmotility, smoking and alcohol overuse. And as you said, overcrowded and things like that also. This also can cause increase the risk of CAP. Okay. Now, how do you assess the severity of CAP? Because the patient is having CAP, how do you assess severity of CAP?
Scores are available, sir. Pneumonia severity index. We can assess the mortality of the patient and related to the admissions also, ICU admission. Then curve 65, and if our CRB 65 without urea, without only clinical aspect we can
CRB
65.
You. Okay,
You.
fine.
And
All
another
right.
one
Okay,
is
without
smart
severe CAP you can consider
smart
COP also.
Very good. Very good. Very good. So yeah. So we this is the importance of this thing is curve 65 as well as pneumonia severity index is that it looks at the predicted mortality rate of this. Okay, both will predict mortality, right? And the lower risk, generally 1 and 2, you can treat them in outpatient OP basis. Moderate risk patient will need hospital admission, like curve 612, or more than that might require intensive care. I see. So admission. So you can look at that also with this. So you're looking at the mortality risk and where to treat them also with that. Okay. So these are the things that you can know. Pneumonia severity index is a little more exhaustive and little more accurate. Okay. But the other one is much more easier to do. Fine. So you also so when you say what is severe CAP?
ATS guidelines, there are again the definition is patient come with a shock needing a vasopressor and a mechanical ventilation. Two major criteria. And
major criteria. Yes.
Minor criteria are there is confusion, respiratory rate more than 30, BP less than 90, and leukopenia, thrombocytopenia,
hypothermia, hypotension, and PF ratio of less than 250,
250.
respiratory rate of more than 30, and any of the three minor
criteria.
minor criteria, and major, any of the major criteria can be considered as a severe case.
Correct. Okay, fine.
So in this patient, what is your impression?
Was this patient having a severe cap or not?
So respiratory rate was more than 30, sir. PF ratio was less than 250, and multilobar infiltrates were there, and urea was also elevated, 55. Leukopenia was there.
So minor criteria
Minor criteria more than 3 is there.
And patient having the respiratory type 1 respiratory failure, probably needing mechanical ventilation.
Right. So
Consider as severe.
Definitely. So you can consider this as a severe cap. Right. So other scoring system, I think you already said this.
That's the SMART.
SMART.
So what is the advantages of SMART scoring system over CUP 65 or pneumonia severity index? What does this exactly tells you?
Regarding the intensive respiratory support, if it is more than 3, you can consider intensive severe. The intensive ventilator support.
This is a more useful tool for intensivist. Okay, this will early predict the risk of progression to invasive mechanical ventilation or vasopressor support early. Okay, score more than 5 is definitely it's a high risk for IRVS, intensive respiratory and vasopressor support. You can see that they have already included an inflammatory markers. Which inflammatory marker is used here?
Albumin.
Albumin is used as an inflammatory marker for the severity of illness. Okay, right. And the other parameters are, as you see, hypotension, multilobar involvement, tachycardia, tachypnea, confusion, hypoxemia, and low pH. Okay, so this is maybe the scoring system might come a much more dominant role in future also for ICU perspective. Okay, right. This is based on an Australian study. Okay, right.
All right. Okay, fine. So, can you tell me what would you get? You're suspecting a patient with pneumonia. What will your focus findings be? You're going to do a focus, right?
Yeah.
First, we have to look for the lung sliding, sir. Mostly lung sliding will be present, and since he's having a consolidation on the left side, I can get a shred sign with associated effusion, and the B lines also sometimes may be present.
Okay.
And
Anything else?
In case of a consolidation, what is the radiological sign that you expect? Focus sign?
Dynamic
Dynamic aerogram. Exit. Hepatization. That is
Hepatization and dynamic aerogram. Yes. Correct. Hepatization, shred, dynamic aerograms. This subpleural consolidation will show C lines. That is, yeah, B lines going from a little below the or broken irregular, the pleural line, and from just below the pleural line, the B lines will start. So that's also their consolidation line or C lines, and of course you can get effusions for these patients. Okay, this patient was shifted to the ICU on around 15 liters of oxygen by NRVM. What is your, okay, so now you received a patient in ICU. This patient is coming. Okay, so what are you going to do?
Your initial management plan.
The patient is GCS
Patient has arrived into the ICU with the NRVM 15 liter oxygen.
The patient is with the full GCS verbalizing. The airway is assume the airway is protected. So, but the breathing is affected with the tachypnea and the saturation fall, and the circulation. There is a accelerated hypertension. So we will manage each by airway is now is patent, but breathing we might be assisted with a HFNO or NIV in this situation. If the patient is purely hypoxemic type 1 respiratory failure, the evidence is with the HFNO. So we'll try with the maximum oxygen HFNO 60 liter, and we can provide around 100% of oxygen. Then we'll start to manage the hypertension. Second.
Okay, so we'll just go through respiratory strategy before we go through the rest of it first. Okay. So yeah. So as you said, you would prefer HFNC over conventional. Why did you say that? Why would you prefer HFNC over oxygen or NIV?
HFNC can provide a heated, humidified, 100% O2 at a flow rate of 60 liter per minute. So it also provides a low PEEP also, and the patient will be much more comfortable with the nasal.
Will that be better than NIV, for example, or this thing? Or is there any studies showing that
Florally trial, sir.
There is a trial. It's showing mortality benefit with the 90-day mortality.
90-day mortality benefit. They have compared the HFNC with the NIV or a supplemental O2 with the mask. So they have shown the intubation rates were similar in all these cases, but they have shown some mortality benefit with HFNC.
In sicker subgroups with low PA of a subgroup analysis did show some reduction in intubation also, but in the original study they did not show any difference in intubation. Yeah, you're right. You're right. Okay. Okay, fine.
So how will you assess response to HFNC? You know, this patient is a high-risk candidate.
So we have to
assess. Once you put them on HFNC, what will you do?
We will assess in second hour and 6 hour and 12 hour ROX index. This is a prediction for the HFNO failure. ROX index we assess with the SpO2 divided by PO2 divided by the respiratory rate. So if it is more than less than 3.8 on the 6th hour, there is more chance of HFNO failure.
And also clinically also we will assess the patient, sir. Whether the patient is comfortable.
That is the best way of doing it. Please do
clinically,
assess them
whether the
clinically.
patient is comfortable with it and it's able to maintain a saturation, and the tachycardia, tachypnea is subsiding, and a repeat ABG also we will do, so that we can see there is any improvement in the oxygenation status, sir.
That's
so you have to assess the improvement in oxygenation relative to the work of breathing. Okay. The oxygenation should improve as well as the work of breathing also should improve to say that HFNC is beneficial. Okay.
So otherwise, it means the patient is not. So clinically, you should be there and you should assess these patients. Okay. So it's very important that you, especially in sicker patients, when you start, you want to look whether there is any signs of failure, because if you miss it, the mortality goes very high.
Very high.
Okay. Yeah. So yes, as you said, a ROX index is also another sign. So a ROX index at 12 hours of more than 4.88 shows a favorable response, and if it is less than 3.85, it's an poor response. So so what is ROX index? As you said, it is SpO2 minus by FiO2 by the respiratory rate. Right. So that's the ROX index, and it can predict intubation and failure from HFNO. All right. And sometimes it's not very clear. So 2 hours, 6 hours, and 12 hours, we do look at that. So
you can see the red boxes. So whenever the ROX index is less than 2.85 at 2 hours, less than 3.47 at 6 hours, less than 3.85 at 12 hours. All three are red flags. You have to consider intubation. Right. All right. The green flags, you see more than 4.88 at 2, 6, and 12 hours. So there are newer HFNC machines which are called incorporated ROX index.
Okay.
The machines will directly tell you the ROX index. You don't know how to calculate it separately. Okay.
But of course you can calculate.
You can calculate it.
Right. So if it is there, if it is in between, you can increase the support and reevaluate.
Evaluate.
And if there's a change in ROX index, then you can consider failure or if the patient is increasing. All right. Is there a role for NIV here?
Role of NIV, if the patient is having any carbon dioxide retention or hypercapnia or a non-case of OAD, COPD or asthma, then we can consider NIV.
If
That
there
too,
is any-
if the PF ratio is more than 200.
If there any cardiac component also, we can use consider.
Cardiac component. And in this patient, he had very high blood
BP,
pressure.
pressure.
So pulmonary edema.
Edema might be.
Yeah, here we didn't rule
46.
out because the BNP was
BNP
normal.
was
Normal. Yeah. If you looked into that, the BNP was normal. So probably not pulmonary edema.
Pulmonary
So maybe not that useful. Okay. And the risk, of course, as I said, is delaying
intubation.
Yeah,
Increases
that
the
will
mortalities.
exactly. That's the problem. Okay. So how do you assess failure with NIV?
The HACO
Score. Yeah. You want to look at the
or
HACO score.
scores.
Yeah.
With HACO,
So-
with HACO score. So
HACO score is
heart rate
and
and GC.
the same clinical thing that you do with HFNC. Please do that first with the NIV also. And the score is to supplement you there. Okay. But the clinical science is probably what you would want to look at the bedside. Okay. HACO score is the additional score that will help you there. Okay. All right.
Are you aware of a recent updation of HACO score? There is an updated HACO score that has been recently published.
No, sir.
Okay, yeah.
Please
So
go
this is the you can refer to this. Okay, updated HACO. Basically, they're adding other issues, and if you look at the score, they put -4 if cardiac pulmonary edema is suspected. Okay, so if you have a pulmonary edema, then
You can reduce 4 points.
4 points. That means NIV might work better. For all the other things, generally,
Okay.
yeah,
So
it might
NIV is risky.
in
NIV
more
is
risky.
more beneficial.
Is more risky. Basically, that's the whole
Message of the
message from the updated
updated
HACO, but go through that. Okay, all right.
Sir.
All right. So, what other investigations will you do for this patient? Now you know there's a pneumonia. All right. Anything else that you'll want to look for?
We will draw blood for blood culture before giving the antibiotic. Surely.
Perfect. Okay. Good.
Then other 2D echo.
You already did POCUS. Okay.
2D echo.
And
No, focus, yeah.
focus then
You will be doing only blood
Sputum
cultures.
available in last for a
If-
sputum also.
If getting
Sorry.
sputum,
Sputum culture. Very,
Sputum
very
Sputum culture
culture
also
Sputum
sensitive
culture.
to severe cap.
and brain strain. Okay, good. Anything else?
Then we can send for a if sputum or if getting sputum, we'll get for a PCR for COVID and
Molecular
Different
diagnostic test
diagnostic
can be also considered.
Yeah. No. Sputum, you don't need sputum for PCR and
Yeah.
this thing. You're going to take swabs for
take
that.
swab
Okay.
for
Yeah. Okay.
then
Influenza, PCR,
Influenza,
other
influenza,
viruses
yeah,
can be done.
influenza,
Okay.
yes.
Okay.
even PCR.
All right. So blood and sputum culture, influenza, COVID, PCR, multiplex PCR respiratory panel is very useful, and biofire and like, and urinary antigens. Urinary antigens are there
For
for
streptococcal or legionella antigen.
Legionella.
If available.
If available, that
Yeah.
can also be sent. Okay. Okay. What are the pathogens you expect in this patient?
Yes, you see the patient is diabetic. and immunocompromised. So we
Multi-lobar involvement.
most common multi-lobar involvement, and with the chest X-ray with the dense consolidation, most probably streptococcal pneumonia will expect this.
It can be
Okay.
bacterial cause. Can be bacterial cause. Mainly
Bacterial
the
cause.
common streptococcus pneumonia. Sir.
If
First
underlying,
pneumonia. Okay.
then
Other than that, what are the other things?
so it can be a viral pneumonia. After that, can be co-infection with the
secondary
bacterial infection. For diabetic, we can consider staphylococcus also, the gram-positive infection.
H influenza. Other common causes are H influenza.
And atypical like Legionella, Mycoplasma, Chlamydia,
Atypicals,
can be considered.
Viral. Yeah, and viral. Okay.
Viral.
So there
Viral.
can be typical pathogens and atypical pathogens. Okay.
Yeah.
And viral. Okay, so you need to cut it in all those three things. So typical, atypical, and viral. Okay, fine. So
Viral.
typical, streptococcal, H influenza, Moraxella. Aspiration pneumonia, usually you get microaerophilic bacteria. Atypical, of course, Legionella, Mycoplasma, and Chlamydia are the usual ones. And viral, of course, influenza, para-influenza, adenocytomegaly, COVID also can be there. Okay. The rates of these pathogens depends on your community and your country. I don't have for India, but this is the US and European. The same. What they're seeing is in the vast majority, around 60-61% of pneumonias, no pathogens are detected. Okay, detected. In Europe, you see that more of bacterial infections are there. In US, it's more of viral. It's probably because a lot of pneumococcal vaccination is being done in the US. We probably have more of bacterial than virus, but that being said, we have a lot of viruses coming up in our community now because of the PCR testing that we are doing. Okay.
Is typical infections are common in Kerala? What is your take on that?
Yeah.
Yes, sir. Typical infections are viral infections we get.
Not viral. Atypical.
Atypical mycoplasma infection. Recently, there was some cases of mycoplasma infection.
Hemolysis also.
Yes. There is an increased incidence of community surge of mycoplasma in last 2 years in Kerala also.
Okay, right. All right. So, can you tell me what are the basic differences that you clinically or in that you would see with typical or atypical pneumonias?
Why they are called atypical pneumonia?
Typical pneumonia is usually with the typical symptoms of cough with purulent sputum, and with fever and with the symptoms of the breathlessness. Typical is usually there was dry cough with less symptoms.
And the patient can have a GA symptoms like diarrhea.
Typical symptoms.
Extrapulmonary symptoms can be common in atypical.
Meningitis.
What else?
Typical X-ray findings also.
For typical, there will be a consolidation, but atypical is an interstitial pattern. It is
your interstitial. So it's clinically different, radiologically different. What about microbiology?
Microbiology. So there is a virus and atypical bacteria. It's very difficult to culture, but with the PCR, we can detect more atypical now.
Will it be visible in gram stain? Atypical pathogens?
Mycoplasma, there is no cell.
There's no
Cell wall. There's no
cell wall. So will that be visible?
Very difficult.
No.
It's basically invisible in gram stain compared to typical. Okay. And the others two are intracellular pathogens also.
Yeah.
So gram stain will not identify typical pathogens. culture, routine culture also will not identify atypical pathogens. So we are diagnosing atypical pneumonia more by molecular diagnostic techniques. Or serology, right? Okay.
Yeah,
So treatment is same or different?
it's different, sir.
Yeah.
For a typical pneumonia, we treat with the
So the antibiotics that is targeted on cell wall, like beta-lactams,
Cell-
will not act on
act
atypical
on the-
pathogens because they don't have a typical cell mycoplasma, right?
Okay.
So it is basically different clinically, radiologically, microbiologically.
Microbiology.
and that's why it is called atypical pneumonia, right? Okay.
Okay.
Fine. Yes.
So I think this is what we
We
are
have discussed all these
discussed
things.
already now. Okay. What are the common pathogens we have said? Atypical will be more insidious. Symptoms
Yeah.
can be also different. I think chest X-ray you did say about
Yeah,
one
that's
is
a
more of
lobar
lobar consolidation, the other one more patchy.
Decision
Patchy.
infiltrates.
Right. Sputum, well, it's not that clear, but sometimes it's purulent and thick in the typical one, while it's much more mucoid or watery in the atypical one. Gram stain, I think Dr. Sethu has clearly said, you will see either the typical ones in the gram stain, while you do not get that in the gram stain. Okay, because there's no cell wall.
Cell wall.
So you cannot get, gram stain will not take up. And routine cultures can pick up typical pneumonia, while a typical pneumonia cannot be picked up by routine culture. And extrapulmonary signs are much more common in atypical, rash, diarrhea, hemolysis, etc., etc. Okay.
Skin
Yeah.
lesions.
Skin lesions, correct.
Meningitis.
And of course, beta lactams will not work on atypical
Atypical
pneumonia.
pneumonia, fluoroquinolones.
Okay, fine. So now we have this patient coming in. Which antibiotic will you give for this patient?
We'll start with a
Beta-lactam.
beta-lactam plus a macrolide.
Beta-lactam and macrolide. Which beta-lactam will you choose?
Probably third generation cephalosporin.
Third generation cephalosporin, ceftriaxone, and which macrolide?
Azithromycin. But still,
Azithromycin.
we have to monitor the ECG QT prolongation.
Okay. Fine.
Any other considerations regarding choice of antibiotics in community-acquired pneumonia?
Sir, doxycycline can be considered, but it can be considered only in mild or moderate. It's not considered in severe community-acquired pneumonia.
So do you want to cover for MRSA or Pseudomonas or Klebsiella in a case of community-acquired pneumonia? Do you actually need to cover or not need to cover?
As per this thing, you are not covered, right?
Yes, sir. If there is a risk factors
Not for this patient, all patients with CAP, do you have to cover for
No, sir.
MRSA?
If there is a specific risk factor for MRSA or Pseudomonas, we will cover.
You cover for that.
There is a previous
So,
sputum culture positive for MRSA or Pseudomonas aeruginosa or elderly or 30 days, 3 months antibiotic use for the previous 3 months.
These are the risk factors. If there is a lung pathology, structural pathology, can be Pseudomonas.
We'll come to that.
we'll come to it. Okay, fine. So, as you said, the standard of care would be beta-lactam plus macrolide or respiratory fluoroquinolone. Okay.
What's the taken quinolones, respiratory quinolones?
Monotherapy with the fluoroquinolones, but it's in our country, TB prevalence, right?
Correct.
We are not considering
You
fluoroquinolones.
have to use it with very
monotherapy.
caution. Okay.
Yes.
You have to use it with caution. Right.
Okay. So azithromycin. So yeah, you have to, and there are some macrolides are supposed to have this anti-inflammatory benefits also.
Yeah.
So yeah, people do prefer macrolides over this thing because of the TB, as you said, and because of this anti-inflammation benefit. Fluoroquinolones could be levofloxacin or moxifloxacin. Respiratory fluoroquinolones can be used. Moxifloxacin can also be used.
Yes.
In some cases. Okay. How do you assess? You send a sample from the sputum. How do you assess the adequacy of a sputum sample?
Smear showing more than 25 polymorphonuclear cells and less than 10 squamous cells in the low power field.
Okay. So that will be
And
a
And yes,
yes.
10 raised to 7 colony forming unit per ml.
what?
And other.
So,
then,
It's only for adequacy of sputum smear. Whether the sputum actually represents
common cells will be common cells should be absent, like
Absent, yeah.
candida, cons, all
Yeah.
these will show
signs of contamination.
contamination.
Are you aware of any criteria?
Any criteria for that?
Which is very commonly used.
Yeah, and the microbiologist always said, if you talk to the microbiologist,
It's called Bartlett's criteria. Okay. Right, let's show that.
so this is the Bartlett's criteria. Okay, they score with that. As you said, PMNs more than 25. PMNs more than 10 to 15 is 1, and the squamous epithelial cells shows -1, and more than 25 squamous epithelium is -2, and if mucus is present, it's +1. So the score is either equal to or less than +1 will be acceptable specimen. Okay.
So what is the importance of ordering a sputum gram stain specifically in a patient with community pneumonia? Is it helpful in your initial empirical choice of antibiotics?
Yes, sir. If there is a gram positive, then we can cover the gram positive also. There is the symptoms with there is no gram stain mycobacterium, then we can think of a typical one. There is no gram stain.
Any other this thing looking at the gram? See, the gram stain you can get. A typical, yes, understood.
Yes,
Looking at the gram stain, will that
and the
help?
morphology of the bacteria,
Yeah.
we'll get the if Coque or Bacilli, we get Bacilli, we can get
You can
Streptococcus.
modify the antibiotics
Like
according to
it's
that. So if you are
Yeah,
not
this
finding
will give
after
you a clue whether
patient
you
is
have
not
to cover
improving.
for additional pathogens.
additional antibiotics, okay.
Additional pathogens. So what will be the gram stain picture in case of a staphylococcal infection? What do you see in the gram smear?
Chains.
it's
it
gram
change?
positive,
Chains.
okay, in Staphylococcus in chain.
Chains.
Pneumococci?
Pneumococci is gram negative.
You can see it. See it here, please.
Yeah. So gram positive diplococci is
It's Streptococcus pneumonia.
Streptococcus.
Gram negative, it could be either Klebsiella or
Klebsiella,
Pseudomonas.
Enterobacteriaceae group.
And if you get gram positive in clusters, it is Staphylococcus
Streptococcus.
aureus. If it is Coccobacillus,
Maybe
Acetobacter. Can get it.
correct. Yes, Coccobacilli generally suggest Acetobacter.
So sputum gram stain is usually an overlooked investigation.
Okay, so you can get this within an hour, and it might help you tailor your antibiotics very quickly. Yeah. Okay, you are talking about the risk factors for MRSA and Pseudomonas. Can you tell me again?
Elderly.
For MRSA, elderly, previous hospital admission,
Antibiotic
use
in the past 3 months, and previous MRSA or culture positive MRSA or Pseudomonas.
Culture positive MRSA. For MRSA, that's okay.
What are the strongest risk factors for MRSA?
Structural heart disease, IV abuse.
IV drug abuse, those who are on dialysis. HB dialysis.
These are all not strong ones, okay. It's there.
So something very important, because when to cover for MRSA in case of CAP is something that
there is a skin infection.
Yeah, there is coexisting skin and soft tissue infections, agree.
Yes.
But if that is not there, there are
Endocarditis.
Endocarditis. There is a structural.
No, we are not going to endocarditis now. When should you empirically cover for MRSA? That's right. Okay, criteria. The strong criteria, maybe the weak criteria. Okay. And for Pseudomonas?
Pseudomonas, if there is a patient having structural lung diseases like bronchitis,
Yes.
COPD,
Yes. Yeah.
or a patient having this older age,
Not really.
previous
So-
colonization,
Previous
previous
culture
positive pneumonia.
positive
That,
failure.
that's very important. That's
Yeah.
very extremely important. If you have a previous
Previous
colonization
culture
or culture, yeah,
positive.
if the patient is on antibiotics in the
But-
last,
Last 3 months, 90 days.
correct, in the last 3 months or 90 days, there's higher chance of both Pseudomonas or MRSA to be present, or resistance Klebsiella also in our setting. All three you will have to think of. Okay. So yeah, here's the strong risk factors and the others. For MRSA, the strong risk factors are known MRSA colonization, prior MRSA infection, and detection of gram-positive cocci in clusters in quality sputum specimen. So that is what will be very strong. So if you see that in the sputum, then you should cover for MRSA. All right. Other factors is recent hospitalization and antibiotic use, especially in the 3 months. Influenza. If a patient had a recent influenza, then there's a high risk for MRSA, post-MRSA. Right. Any necrotizing or cavitatory pneumonias in the X-ray, if you see necrotization of the cavity, then you'll have to consider MRSA. Any empyema or effusion, you'll have to consider, or complicated effusion, especially, you'll have to consider immunosuppression and other MRSA factors, as we said. Okay, kidney disease, crowded injection, men having sex with men, etc., etc. Okay. And for Pseudomonas, the strong risk factors are, again, patient with a known Pseudomonas colonization. Yeah, any prior Pseudomonas infection, exactly like MRSA. Okay, if you have known colonization of infection, and gram-negative rods in sputum, that's also important. Here in India, we do have a lot of Klebsiella also, so it's not just a Pseudomonas. And hospitalization with IV antibiotics in the prior 3 months is a very strong risk factors for Pseudomonas. Other factors, of course, is recent hospitalization or stay in a long-term care facility, any recent antibiotic use of any type, any kind, patient with COPD who requires glucocorticoids or antibiotics, and structural lung disease, as you said, bronchitis, especially cystic fibrosis, and immunosuppressed patients. So these are the risk factors for MRSA and Pseudomonas. All right. So what are the drugs for the empirical coverage of MRSA?
Can consider vancomycin 15 milligram per kilogram, 12th hourly, and linezolid 600 milligram IVBD.
Okay, if you want to choose for this lady, which one will you choose? Linezolid or vancomycin?
This one is we choose all vancomycin because patient is having the total count is less 2000.
Okay.
Can cause bone marrow suppression again. Linezolid. So we'll consider vancomycin.
So you would consider vancomycin. What would make you choose one over the other is what you would want to know. Okay. Where is vancomycin definitely helpful or definitely superior to linezolid in a certain situation, which can always coexist with CAP?
Suppose this patient is having a pneumonia with sepsis or bacteremia. What is your choice? Vancomycin or linezolid?
Blood culture is starting.
Blood culture is also positive.
Yeah, the GPC growing in blood culture. Next day somebody is calling you. Which one will you choose?
Vancomycin.
Why?
So, more bactericidal effect of cell wall destruction, and can cover the CNS coverage also.
So, linezolid has got a exotoxin producing.
Exotoxin producing or
It
toxic?
can inhibit the exotoxin.
It can inhibit
Inhibit
exotoxin. So,
exotoxin. So it is
okay, good.
preferred
Linezolid.
in this scenario that linezolid is more preferred than vancomycin.
Right. No, we didn't give you this thing that, 2 days later, I started this thing, and 2 days later, the microbiologist is telling you there's some gram-positive cocci growing in the blood, starting to grow in the blood. It's bleeped, and then, it's gram-positive. That's what you get, no? They're not found out what it is, but something gram-positive is growing. Now, what will you do? Which one will you give?
So in a bacteremic settings,
Septicemia. There's a septicemia going on.
what is your preference, vanco or linezolid?
Septicemia.
Not in a pneumonia at all. Isolated pneumonia is not there. Pneumonia with the bacterium.
Bacteria.
Yeah.
Bactericidal or is vanco.
Vancomycin.
So vancomycin.
It's vancomycin.
Vancomycin. we will prefer.
Why? Because
Bacteria.
the studies have shown that in septicemia, vancomycin has mortality benefit. Okay. Linezolid is not as effective in septicemia as vancomycin. So you would definitely prefer vancomycin if there is a septicemia going on. All right. If there is no septicemia, suppose there is no septicemia, vancomycin or linezolid.
Linezolid.
It's all good. There is no mortality benefit for CAP per se, either vancomycin or linezolid. Both can be used. The problem with vancomycin is large molecule. Penetration into the lungs is lower with vancomycin, but it's a better molecule, so it will kill more. Okay, once it penetrates. While linezolid has very good, excellent penetration into the lungs, but it's not as effective. So outcome, mortality benefit is reasonably the same. That said, there are some few studies which showed some slight benefits with linezolid in some cases, especially necrotizing pneumonia. Where you want to reduce the exotoxin. If you're suspecting necrotizing pneumonia without septicemia, linezolid, especially to suppress the exotoxin. Yes, that is also a reasonable option to start. So remember, but if there is septicemia, you should go with
vancomycin.
If it is not there, both are reasonably equal. But yeah, if you want to suppress your toxins, then linezolid is a good choice too. Okay. So, okay, what are the anti-pseudomonal antibiotics? You're suspecting pseudo, okay? The sputum sample has come as gram-negative rods. Now you want to start anti-pseudomonal. You prefer an anti-pseudomonal. So what are the drugs you can choose?
We can choose piperacillin tazobactam.
Okay.
And 4th generation cephalosporin.
Fluoroquinolones.
Fluoroquinolones, 4th generation cephalosporin.
Can be okay. Yeah, okay. 4th generation. Which ones? 4th generation means cefepime. Okay. And any 3rd generation?
Ceftazine.
That generation is.
Okay. Anything else?
Carbapenems.
Yeah, carbapenems. Can you give all carbapenems?
No.
Which one will you not use, or which will not cover pseudomonas? Imipenem does cover pseudomonas. Okay, it's etrapenem. Etrapenem will not cover. Etrapenem will not cover pseudomonas. Okay, so piperacillin tazobactam, as I said, cefepime, ceftazidime, or meropenem or imipenem can be used. Doripenem also can be used if you have it. But not ertapenem. Okay, that will not cover anti-pseudomonas. It's not an anti-pseudomonas.
So
All right. Now, this patient has come. Actually, this patient came around 10 days back to our ICU. So now, will you give her antiviral drugs?
severe cap, we can consider antiviral drugs before the PCR comes.
Before the PCR comes. Yeah, okay.
If patient is in severe cap.
If patient is in severe cap, you can definitely, yeah. So the recent, recent ATS guidelines have start empiric antivirus immediately for any patient with cap during influenza season, and right now it is definitely influenza season. Okay.
During influenza outbreaks, all hospitalized patients with respiratory infection and community pneumonia has to be covered with empiric antivirals.
Antiviral. Okay, right. You do not have to wait for molecular confirmation. You can start and you can de-escalate once your molecular comes negative. All right. So that's the idea. And for severe disease, should be start even if it is after 48 hours. Normally, this thing is to start antivirals within the 48 hours window. But there is evidence now to say there is in severely ill patients, starting it even up to 4 to 5 days post onset, there is benefit. So if severe progressive disease is there, do start. Okay, and you can start it even later if it comes positive. Just because it's not after the 48 hour, don't stop. Please do treat them. Okay. Will you give her adjuvant steroids?
According to the guidelines, steroids are indicated only in the severe cap.
Yeah, this is it. This patient is a patient with severe cap, right?
Steroids, severe cap.
Yeah, this is a severe cap. Is it? So you are going to give for severe cap.
Yeah, evidence also suggests the Cape Cod trial showed a mortality benefit if given hydrocortisone 200 mg daily, 50 mg daily.
To patients with severe cap.
More on the hyperinflammatory patients.
Yes, right.
With
Very
the
good. Very
CRP
good.
is more than 50.
Right. So the theory is that early corticosteroids will reduce the hyperinflammatory response and prevents ARDS and reducing 28-day mortality. 28, yeah. So usually you treat patients with severe cap, that is invasive or non-invasive ventilation, with severe hypoxemia. Usually FiO2 ratio less than 300 with an FiO2 of 50. This is what the Cape Cod did. Or patients with high flow nasal cannula or non-trivial mask also. Okay. They also looked at patients with NIV, I think. The regimen was 200 mg daily, usually continuous infusions, hydrocortisone.
Continuous infusion.
Right. And usually, duration is 4 to 7 days and taper down, usually up to 14 days. Mortality benefit was greatest when it was started early, that is within 20 hours of admission. Okay, and it has been shown to reduce endotracheal intubation and vasopressor initiation. All right. Okay. The question is, when will you not start steroids?
The patient having a GI bleed or a uncontrolled diabetic and
for this patient, for example,
influenza, post-influenza patient.
Right.
And
right. Influenza also you should not give. So contraindication.
Influenza.
All right. Influenza. Anything else other than influenza? All right. Influenza is it? Okay. Influenza is this thing. It impairs the immune control and it increases mortality in influenza. So definitely in patients with influenza, you should not give steroids. Fungal pathogens also, there's a risk of dissemination. So you will not want to do that. TB. Any patient is suspecting TB, it can, worsen the disease, so you will not want to do that. Also, any patient with an active viral hepatitis or herpes, because of the potential of flare, you will not want to do steroids. Okay, so these are the contraindications generally of steroids. Okay. And of course, mild to
moderate cap, it is not indicated.
only in severe cap it is indicated. Okay. Okay, this is the Cape Cod trial, which you referred to. Which showed that hydrocortisone decreased the 28-day mortalities in patients with severe community-acquired pneumonia. What are the role of biomarkers in these patients? Is there a role?
Yes. CRP definitely have a role. One basically for the steroid and for serial monitoring.
And if it is less than 100, we can exclude as a severe pneumonia.
If there is less mortality, there is if
ERP is not enough.
Basically, as you said, we have clinically we have seen the usefulness of CRP, but it has not come as a recommendation as per the ATS or IDSA guidelines. Okay.
To look at that level and then change it
To identify the
severity. Yeah, we have other things for severity.
The clinical severity criteria has been recommended in
guidelines. Okay.
Even though practically we use, as you said, the inflammatory biomarkers to assess the severity, the guidelines say to go for clinical criteria only. Okay.
Right. So any other biomarker that you
procalcitonin, sir.
What's the role of PCT?
Yeah. What is
PCT,
only for the de-escalation of the antibiotics if it is decreasing. Should not use
for initiation of antibiotics. It is not suggested. Again,
initiation should be shown that
initiation should be a clinical decision.
Should be clinical decision, not based on the procalcitonin. And the ProHosp trial has shown that it is useful in de-escalation of antibiotics.
De-escalation or stopping?
Stopping.
Stopping escalation, not de-escalation, to stop. Okay. When will you stop it? How much? When will you, according to looking at PCT, when will you stop?
Serial.
Yeah, you need serial and then
serial. You have to look at serial. Less than
25%.
Less than 80%.
80%.
Less than it's less than 80% reduction, or less than, I think, 0.25.
Less than
0.5 absolute value, or 80% reduction for the peak value. You can stop your antibiotics. There are other caveats for that. We'll come to that. Okay. Before stopping antibiotics. Okay, fine. So about this patient was started on ceftriaxone 1 gram BD, azithromycin 500 mg OD, and oseltamivir 75 mg BD. Her respiratory status deteriorated despite an HFNC trial, and she was electively intubated and ventilated. Her clinical status and oxygenation improved over the next 2 days. Okay. And the cultures came negative, nothing grew. And influenza A was positive. Okay. With PCR. Right. Pardon?
Yes.
Go ahead.
This moment we will cover a gram-positive
MRSA coverage also we will add
because of the influenza
and the deterioration of the patient clinically.
Yeah, because there was the first 2 days she improved.
Later she
and then later she deteriorated.
Will you stop antibiotics at this point? Will you de-escalate based on the cultures?
Cultures are negative.
No, sir.
No.
Now the ATS guidelines 2025 is recommended the for severe cap we can treat with antiviral and antibiotics.
Here it is a superadded bacterial
Superadded
infection.
bacterial.
Possible.
It's not a single pathogen. Definitely there is a double hit. Okay. Influenza with a superadded bacterial infection is expected.
All right. So we need
Let's
to
see.
cover. As I said, even in 60% of your cases, you will not get cultures. Okay, bacteria cannot be identified in
Isolated
60% of your
culture.
bacterial of cats. So that is not enough to stop your antibiotics. Okay. All right. We did. Excuse me. Then we did a CT because she was worsening, and this was the CT. This was what the CT showed. Can you comment on the CT, please?
CT of axial section. One is the right one is on the lower side,
Yeah.
around the at the level of pulmonary trunk, which is showing a left-sided consolidation with the air bronchogram, posterior upper lobe, posterior side with the air bronchogram, and the left side is more on the uppercut. On the apex, there is a consolidation with the parenchymal destruction. It's going to have a there is mild there is pneumothorax also.
വെക്കുന്നതല്ല സ്ലൈഡ്സ് അല്ലേ നല്ല അതായത് ഓരോ സ്ലൈഡിൽ ഫസ്റ്റ് എന്താക്കിയ നമ്മൾ ഡിഫറൻഷ്യൽ ചെയ്യും നെക്സ്റ്റ് സ്ലൈഡിൽ അത് കിട്ടത്തില്ലേ
There is a developing minimal pneumothorax or a lung destruction with minimal pneumothorax.
Yeah, it was actually not reported as pneumothorax. So what you see is,
abscess is developing.
exactly going for necrosis and
necrosis.
The pneumonia is actually associated with some form of cavitation and
Cavitation.
necrosis. So what does it suggest?
There is a superadded infection with the gram-positive, maybe Staphylococcus
As we have already said,
there is a pneumatocyl formation.
Yeah, this patient is possible of a Staph aureus infection.
Staph aureus infection.
Very possible. Okay, so
post-influenza, you are getting a necrotizing pneumonia-like picture. Apart from the pneumonic consolidation, you can see some loculated pleural effusions are also.
Yes. Pleural effusion. Yes. Okay.
So what other additional interventions you will do with the CT? Once you see the CT, what is your next plan?
Definitely we will cover the
we have to cover. Yes. So this patient was added with linezolid. Okay, right.
So, and
we went for a diagnostic thoracocentesis. Okay, right.
So this was the pleural fluid study.
Or like a parapneumonic effusion, which is the protein is.
Is it an exudate or a transudate?
Serum, according to the Leitch criteria, it's more than 1.5. And the LDH is more than 1,000. It's showing it is more than 2/3 of the serum. So it is exudative pleural effusion. Most probably parapneumonic infective.
What is Leitch criteria? Can you tell us?
Leitch criteria is serum protein divided by the
pleural fluid protein of more than 0.5.
More than 0.5, and LDH is more than pleural fluid LDH divided by serum LDH is more than 0.6. and if LDH is more than 2/3 of the serum LDH.
Okay.
Okay.
So if any one of these criteria is positive, the pleural fluid is an exudative.
Exudative.
Right.
So there are certain caveats, especially in patients on diuretics. You might falsely label transferase as exudative. Okay, so in this situation, some other criteria also serum pleural albumin gradient.
Sir.
Okay, the serum pleural albumin gradient, if it is more than 1.5
Two.
grams per deciliter, it can be looked at as transudate. Okay, and serum protein and serum and the
Protein.
pleural protein gradient more than 3.1 gram per deciliter is also a transudate. Sometimes, otherwise, in patients with diuretics, this protein thing can sometimes be wrong. Okay, so that's why we need to do additional. Let's see. All right.
So that's called modified Lights criteria. Okay.
Okay.
Right.
So was the ADA high on this patient? It's 45.
Yeah, its cutoff value is 40 and 45 is high. But it is sometimes falsely positive also. It's lower level because of the WBC count in the pleural fluid is high and might be can be false.
High value. So ADA shows for you're looking for
Tuberculosis.
tuberculosis. So, all right. Okay. So usual this thing is less than 40, it's unlikely, and more than 70, it is definitely very strong suggestion of TB. But between 40 and 70, it's a little confusing. Okay, it can be TB. Yeah, it can be TB. But can you tell me other causes of high ADA inefficiency?
Apart from tuberculosis.
Except tuberculosis, yeah.
Empyema with very high neutrophils.
Yeah, empyema is one of the causes, yes.
And any malignancy, CLL, like any
Lymphomas.
neoplasm,
Yes.
lymphomas
Okay.
can cause ADA. And any mesothelioma. Yeah.
Yeah, as you said, parapneumonic effusion. So empyema is one of the commonest cause for having higher ADAs. Okay, so don't get misled with slightly high ADAs. Lymphomas, rheumatoid pruritus, malignancies, fungal infections, and hemothorax. All of that can cause increased ADA inefficiency. Okay. All right. So what are the other supportive measures, general supportive measures you will do for these patients?
DVT prophylaxis, sir. Should
Right.
consider a DVT prophylaxis.
Mhm.
In
Nutritional
Okay.
steroid.
Yeah.
Steroid.
Steroids we
no
give it for
because
this
of
patient?
the influenza. No.
No, we won't consider. It's influenza.
Influenza positive, right? Yeah.
Yes.
DVT prophylaxis.
Chest physiotherapy with
The usual this thing would be that fast tag bits in ICU.
Yeah.
What are the fast tag bits?
Feed.
Yeah.
Analgesia, sedation, thromboprophylaxis, head and elevation.
Yeah.
Bladder.
She's intubated now, so yeah, definitely. Yeah.
Isoprophylaxis. Maintaining a GRBS value of less than 180.
Yes. Very important for this lady who is diabetic, right? Okay.
And bowel and bladder.
Lines.
Any invasive lines.
We have to take care.
And
the medication.
If it's not needed. Yeah. Okay. Drugs. What about the drugs?
De-escalation.
De-escalation
De-escalation of the drugs.
All right. De-escalation of drugs. So you need to check it every day. Okay, whether you can remove the lines. If the lines are not needed, remove the lines. If drugs can be de-escalated, de-escalate the drugs. So this has to be checked daily. So that's something for this lady, because she is hypertensive. You will have to probably take care of the hypertension also on top. Okay.
Hypertension.
All right. Yeah. So this lady had worsening counts, a new fever started coming in, and we did an X-ray, and this was the X-ray. Can you comment on the X-ray, please?
X-ray is showing homogeneous opacity on the left side, the whiteout line. Most probably the trachea is on the middle position, so it is collapse with maybe effusion, because it's not shifted, not purely collapse with effusion. Massive effusion.
Massive
effusion is what you think. Okay. Why? No?
mediastinum and the trachea is shifted to the other side.
Mediastinum shifted to the other side, and
This side.
you can see that ET tube, it's getting
Yes.
pushed to the opposite
Opposite.
side. Right? Collapse, you expect the
Same
mediastinum to go to the same side. Same side. So this is probably more of a effusion.
Effusion with the
Effusion. Yeah, or reasonably massive effusion.
effusion with the
Shift in the mediastinum, right?
Yeah, maybe consolidation.
Consolidation, possibly a consolidation is also there because on top of that, because we know there is a pneumonia there. Okay. So what are the complications of pneumonia?
complications.
You
Abscess.
can explain.
On the pulmonary complications, we can there is a local lung abscess, empyema, pleural effusion, hemoptysis, and there is long extrapulmonary multi-organ dysfunction, AKI, and
Yes.
so a typical maybe there is a meningitis and other extra pulmonary complications, and long-term complications like bronchiectasis and cardiovascular because of the pro-inflammatory state. There is a
Okay. So basically, pleural phase complications can be pneumonic, parapneumonic effusion, like this patient had, complicated parapneumonia or empyema. The lung abscess or necrotizing pneumonia can complicate the parenchyma itself. Respiratory failure, ARDS, and modes are this thing. And as you said, for atypical, you can get other signs too sometimes. Yeah. So what is a parapneumonic effusion?
Will you define a parapneumonic effusion?
Effusion with a underlying consolidation, with the effusion also having the WBC count more than with infected effusion.
So
Pneumonia, okay. So that's not the pneumonia only. Okay.
So the parapneumonic effusion is defined as pleural effusion that develops as a result of pneumonia, lung abscess, or bronchiectasis. Okay.
All those three things. Okay. Not just pneumonia.
Okay. Right. So it can actually extend from a sterile fluid to frank pus. Okay. Right. What are the types of parapneumonic effusion that you know?
There is a exudative and transudative, and
parapneumonic effusions are usually exudative or transudative.
This is exudative.
Exudative, always exudating.
Always
Exudative.
exudative. Okay. So how will you classify parapneumonic effusion? Because it affects the management.
Complicated and non-complicated.
Yes. It is being classified as
complicated,
complicated, and empyema. Right? Okay. So what is the difference between these three?
it's non-complicated is there is a pH. If complicated, the pH is less than 7.2, and there is a cells more than WBC cells infected, and there is less glucose. And in empyema, there is frank pus.
Yeah.
So the chlorophyll biochemistry can help you to differentiate between uncomplicated, complicated, or empyema. Okay. Similarly, if you look into the property of the fluid in the ultrasound also, we can have an idea whether it is an uncomplicated, complicated, or empyema. So in uncomplicated effusion in the ultrasound, we will usually show it as a free-flowing effusion. Meanwhile, once it becomes complicated, you will be able to see evidence of loculations or fibrin strands. In the empyema, you can see the thickened pleura and in the ultrasound. Okay, right. So the difference, what's the difference in the management in these three cases?
In uncomplicated empyema,
Uncomplicated parapneumonic effusion,
we have to
it
drain.
actually requires antibiotics alone. There is no need for a ICD or a chest drainage. Okay, it's a very early stage.
Yeah.
So once it has entered into a complicated parapneumonic effusion, you have to consider drainage. The mandatory drainage is required. Similarly, about empyema also, mandatory drainage is required. And then additionally, you can consider intrapleural instillation of fibrinolytics. Pleural instillation of fibrinolytic agents to facilitate the drainage. Is it clear?
Yes.
Right. Okay. So what are the indications of ICD in parapneumonic effusions?
We didn't go through it now, but yeah.
Yeah, if there is a effusion, is complicated or empyema, if there is, we have to definitely put an ICD.
Correct.
And if patient is having respiratory compromise due to the effusion, we have to drain it.
Massive effusion.
And the patient radiology finding may showing the loculated effusion. We have to do this.
So any symptomatic effusion which is occupying more than 50% of the hemithorax has to be drained. Then evidence of clear-cut infection in the pleural space with the loculations like frank pus, positive cultures, biochemistry, air fluid levels. All those things are the indications for ICD drainage. Okay, right.
Okay, this is after the ICD was put. The chest is showing some improvement after an ICD was kept. Okay. What are the indications for intrapleural fibrinolysis?
Are you aware of any trials?
Yes, missed trial, missed one and two. Miss one trial is only with the fibrinolysis, but it was not showing any improvement. Miss two is with the fibrinolytic with the DNAs showing benefit of DNAs.
Right.
So
okay. Indications for
indication for fibrinolysis, there is a septated, highly septated pleural effusion which cannot be drained fully with the ICD. And there is a pleural thickening.
complicated or pleural effusion of empyema. That's what we said, no? Inadequate drainage despite having a chest tube, then you need to put it. Okay, you put in the chest tube, but it's not draining. And if the ultrasound is showing loculations or multiple septations, that would be an indication. And patients who are poor surgical candidates for more invasive procedure like VATS, or if you do not have a thoracic surgery availability in your institution also, this can be considered. Okay. And best time for intervention is usually within around 72 hours, before 72 hours. Once the poor drainage from the standard chest tube is recognized, within 72 hours, please do the intrapleural fibrosis. Okay, fibrinolysis. Yeah.
Let's try.
Yeah, the trial you said, you did say about the MISS trial. Yeah. it did look after, as you said, looked at TPA with DNAs, and it
DNAs.
definitely showed it reduces need for surgery, and the hospital length of stay was also reduced. Okay, and it worked when both were used together. Oh, sorry. Okay, fine. I think what is the recommended duration of antibiotics in CAP?
CAP, it's if only in severe CAP, it is more than 5 days till the radiological, chemical, and clinical improvement we get.
In
Radiological improvement?
Radiological will take how long?
No, clinical and
clinical stability. If the patient has attained clinical stability, we can consider 5 days. If a patient without much comorbidities
5 days.
and
5 to 7 days. Yeah. Okay, fine. So when you say clinical stability, what criteria? When will you say a patient is clinically stable?
So there are
febrile.
ATS,
Patient is
recommendations.
clinically patient is febrile for the past 48 hours. There is no tachypnea, tachycardia.
And
And
PF ratio.
improving PF ratios.
And
you shouldn't stop antibiotic if any of these are not met.
All the criteria for
Has to be-
clinical stability has to be maintained.
Okay,
before
before you
stopping
stop
antibiotics.
antibiotic.
So they have clearly explained the clinical criteria,
Right.
the guidelines.
there is a increasing count or
The clinical criteria.
Clinical criteria.
Clinically,
Just have a look at
ongoing
this.
fever.
Yeah, this is it. Okay.
BP,
Fever should not a normal temperature for more than 24 hours. Heart rate should be less than 100. The respiratory rate should be less than 24 breaths per minute. Systolic BP should be more than 90. Oxygenation should be more than 90 again on room air. Okay. Or mental status should be normal or baseline, and patient should be able to take oral intake. Okay.
The point is, the patient has to meet all
criteria before you
Vitals.
stop antibiotics.
All criteria has to be met before
Before you
stopping the
stop.
antibiotics.
Stopping
If all this is there, then in 5 to 7 days you can stop antibiotic. Okay.
So how long will you give antibiotics for this particular patient? What's the take?
This patient.
Since it is MRSA, we have to continue IV antibiotics.
We're not sure about MRSA.
MRSA has been negative.
Nice.
We didn't get
Cultures
any
are negative.
isolates. It's an empirical
Treatment.
based on the
Because we saw that.
radiological features.
Uh,
It was
Really?
not culture problem.
This clinical improvement.
So will you stop antibiotics at 7 days?
No,
For this
sir.
patient, if all this is there.
Yeah,
Ah.
sir. If clinically patient is improved with this, we can stop.
Did you have any complications? If you have complications,
14
will you
days, for 2 weeks.
say if you have complicated pneumonia, you're
So please have a look at this.
look at this
Ah,
slide.
look
Okay,
at
so if you have complicated
Yes.
pneumonia, your criteria is different. If you have parapneumonic effusion or M5,
As in this
M5
patient,
Okay,
this
she had.
patient's pneumonia has been complicated by parapneumonic effusion.
Effusion.
So she needs a prolonged duration of antibiotics
Antibiotics.
of at least 2 to 4 weeks.
So 2 weeks, if it is very good drainage is there. If it is drainage is not there, you might have to go up to 4 weeks.
4 weeks.
4 weeks. Okay. If you have good drainage, then 2 weeks should be good enough. Okay. In lung abscess, around 3 to 6 weeks till radiological resolution or stability occurs. Okay. For MRSA, again, nearly 2 weeks is what you need, and especially if there is necrotizing pneumonia or bacteremia, you need to go for 14 days.
And you have to rule out that the infection has not metastasis.
Okay, so
MRSA
MRSA, you need to look at an echo and ophthalmo examination also. All right, okay. And Pseudomonas again, usually 7 to 14 days. More if there is especially structural lung disease, mostly 14 days. Okay. And necrotizing pneumonia also 14 to 21 days. All right. Okay. So not all pneumonia is 7 days. Okay. So uncomplicated pneumonia, yes, 7 days. Complicated, it can vary. All right. So okay, it's already okay, fine. Sorry. So what is unresolving pneumonia?
And resolving pneumonia
Winding up.
is
Yeah.
Yeah.
That's
and
all
resolving
right.
pneumonia there is no clinical improvement or radiological improvement with the antibiotics.
Initial antibiotics.
We have to suspect there is a wrong
Then we have to recheck the
diagnosis or
So yeah, your normal resolution, if it's not improving in the normal time is what we look.
No.
Pneumonia that fails to show expected clinical and radiological improvement.
So the clinical improvement usually occurs within 72 hours.
If it doesn't there, then you have to start suspecting.
Clinically.
And
If you're based on X-ray, you can see that it may take up to 2 weeks to show more than 50% clearance. So the X-ray clearance lags behind the clinical improvement. So you can wait up to 2 weeks before labeling it as an unresolving pneumonia, provided the patient is clinically improving. Okay. Right. And usually in elderly, it may take up to 4 to 6 weeks to get the complete radiological clearance. So these factors has to be kept in mind before considering for additional investigations. Okay, right.
okay. So how will you work up for unresolved pneumonia?
is and we have to go for a we have to check the diagnosis is correct because of the maybe we'll send a repeat culture and we'll consider
Imaging.
coverage of the antibiotic. We have to recheck we are covering the appropriate antibiotic, but we have to check for TB, fungal infections and other things.
Right.
We have to check for neoplasm or any other.
So you have a reasonably nice mnemonic for it. We call it bad omens. Anyway, bronchial obstructions because of cancer, four-leaf plugs or something like that. Atypical pathogens, TB, fungal, nocardia, actinomyces. Drugs-induced lung disease like or distant infections like empyema. Organizing pneumonia or other mimics like vasculitis or pulmonary embolism, malignancies, especially bronchogenic carcinoma and lymphoma, eosinophilic pneumonia or embolic events also, and non-infectious inflammatory states. So it's a so sarcoidosis. Okay. Okay then. So thank you. I hope you had a good time. So I think we'll end this session here. Okay.
Thank you, sir.
Thank you.
Raja sir.
Yeah.
Hello. Raja sir.
Yeah. Go ahead. Yeah. Shall we end this session here now, Rahul? How is it?
Yes, sir. One voting notes from our chairman, Mr. Raja. Raja sir, are you there? Jaya?
Yeah. I'm good. Let me check with sir.
Yeah. Otherwise,
Sir, am I audible?
Yes.
Yeah, okay. So Good evening, doctors, once again, and it's been a wonderful session. Thank you very much, Dr. Matthew and his colleague. It's been extremely happy to have this 1.5 hours of session. It's almost close to 1 hour and 45 minutes. And we had close to about 60 to 70 participants, plus additionally few of them in the YouTube. Kudos to both the examinees also. I think they've also done a good job. I think Matthew sir is the right person to give a comment on that. So, but otherwise, I think every student must have enjoyed this today's session. So we really look forward to meet you once again in the next session. The recordings of today's program will be telecasted in the YouTube. It will be live streamed from Monday onwards. Means it will be the recordings will be available on Monday. So until then, we look forward to see you in the next week. Until then, bye. Thank you very much. Have a great weekend.
Thank you, sir.
Thank you. Thank you very much. Yeah.